Hi, everyone, and welcome to the microdosing panel. I want to start by thanking Prohibition Partners for inviting us all. I'm Michelle Janikian. I'm a journalist mostly focused on psychedelics and the author of Your Psilocybin Mushroom Companion. And I'd like to introduce our panelists for today. First, there is Sophia Korb. If you'd like to quickly introduce yourself.
Sure, I'm the director of research at the Fadiman Group. I do large-scale longitudinal research on people who are microdosing.
Wow, cool. And David Luke, could you please introduce yourself?
Yeah, sure. I'm an associate professor of psychology at the University of Greenwich, and I'm also honorary senior lecturer at Imperial College at the Centre for Psychedelic Studies, and I'm also a lecturer for the Aleph Trust, Masters in Consciousness, Spirituality, and Transpersonal Psychology. And I do lots of research on psychedelics.
Very cool. So excited to have you here. And also, David Eritzo, could you please introduce yourself?
Yeah, hi. I'm a clinical psychiatrist and also a senior clinical lecturer at Imperial College in the Neuropsychopharmacology and Center for Psychedelic Research, where I'm also the clinical director. And
Awesome.
we also conduct psychedelic research, including microdosing. Yeah.
So exciting. No, it's such an honor to be here with all of you today. You all are doing such interesting work. I'm really excited to dive in. So I thought we could start, really generally, maybe by defining what a microdose is. I'm also curious, what does subperceptual mean and how the microdose experience differs from a full dose psychedelic experience? Does anyone want to take that one?
I can jump in because the subperceptual thing is our fault. Jim Fadiman heard about microdosing from a student of Albert Hoffman's, and what we meant to write is that it's below visual perception. Not that you can't tell that you've taken a microdose, but that it doesn't change anything in your sensory perceptions. But that's been really confusing, so we've been trying to explain what's been meant by that. So microdosing in general is taking a substance under what a regular dose would be to create a different effect. So there's microdosing of, say, hormones as well, where people take a very small dose and it has a different effect than taking a larger dose of that hormone. Or say, ultra low dosing naltrexone, which has a different effect than a regular dose of naltrexone. So that's basically what microdosing is, what people report. So Albert Hoffman thought it would be around a third or a quarter of a regular dose of LSD would have beneficial health properties. So what it turns out is that much lower doses, like 1/10 or 1/20th of a regular dose, people report increase in creativity or decrease in procrastination. It helps with mood, with depression, but it seems to increase anxiety slightly. And so there's sort of a host of different positive effects that people report.
Thank you. Yeah, no, that's super interesting. I guess I've always wondered, how important, I know in most clinical research with psychedelics, we talk a lot about context, about set and setting. And I don't really hear it talked about so much with microdosing, but I was wondering if there is some importance to set and setting with microdosing. Maybe David Eritzo, maybe you want to take that one?
Yeah, it's a good question. For the full doses, I think everybody who works in it or have experience in it, also from real life, pay a lot of attention to the context. With microdoses, it's a bit different because people are taking it very regularly, typically when they go to work. If you work in Google and want to be very creative and develop a new smart app, then you just go to work and do your thing. So therefore, naturally, it's a bit difficult to pay the same degree of attention to the setting. But I think this stimulation of this receptor that the psychedelics stimulate is increasing influence and sensitivity to the context and to what's around you and what context you're in. So I think it in a way it is important, but maybe a little bit like context is also important for the action of normal antidepressant drug like SSRIs and so on. But I think it's probably more easy if you want to manipulate the environment. You can probably more safely experiment with that in a sort of scientific setting if you want to examine the meaning and the influence and the importance of context and setting. That would be probably safer and smarter to do in microdosing than full doses, because that would be proper risky most likely.
Yeah, no, that's really interesting. I appreciate you going into that. Yeah, so you know, a lot of the hysteria like around psychedelics originated in previous decades is still kind of commonplace in many communities. When you start talking about psychedelics, you get that look. And I guess I was wondering, like, what steps can the psychedelic science community take to improve the public perception of microdosing? David, Luke, you want to take that one? Maybe.
Yeah, I think, well, first of all, we have to produce better science, and it has to be kind of go hand in hand with better education as well. So we need to learn more about these substances and the kind of the safest context for their use. I mean, there's pretty good evidence to suggest they're pretty well physiologically very safe relative to many other drugs out there. And it's about education, not just of the mass population, but also of users as well, so that people experimenting with these aren't actually kind of getting themselves in harm and kind of tarnishing the fantastic reputation that we've established for these substances in the last decade or so. So I think those are really important things. But I think we are seeing a kind of a massive change in kind of public perceptions around these things, but there are still some prejudices, of course. You know, there was a big legacy in the 60s.
Yeah, no, please.
Sorry, I also have a comment here. So I think it's the first thing that David Luke said about that doing good science. I think that's quite key in this specific question, because if it's about sort of calming down, promoting something that is safe and maybe beneficial, so that only makes sense if we know that it is beneficial, if there are effects, and that it is safe. So therefore, without having proper science, the real studies to do it, because there are a lot of evidence, but that evidence is pretty weak at this point. Therefore, you need more evidence before it even makes sense to go out and try to change anybody's opinion, I would say. I think this is a bit early days for microdosing. And also, we can't really say, oh, these decades of this and that. Yeah, that's for psychedelics true, but for different use of it, full dose, this is more new phenomenon, and we know less about whether it does anything proper beyond placebo.
Yeah, I think like David's words there for sure. That's where my stand on it as well.
Yeah, no, I agree. As someone who's kind of well versed in the research, I do feel like a lot of it is anecdotal self-reports, right? And I guess I was wondering, I wanted to ask each of you, what is a study or some studies that you'd like to see about microdosing, you know, that could in the next few years? Like, what's your dream study on microdosing? Maybe we can start with, you're still here, right?
I lost you for a sec, and I wanted to jump in on the last question. I'm not sure what you just asked, though.
Well, why don't you jump in on the last question, and then I can ask it again. It's no problem.
Yeah, so I think having better science education in general is really key to this. So people, they want to ask for is a randomized double-blind studies, but they don't know why, and they don't know how to contextualize having anecdotal evidence, and in the ways that that isn't randomized, what that data can be used for. So, for example, we in collecting evidence about microdosing, we put out information, but we've never encouraged people who have had a bad experience on LSD or psilocybin to take microdoses. So we're naturally excluding all of those people who say might be really inclined to have a bad experience. So it's really important to contextualize the because we have a lot of stories from people who like microdosing, but that's a really specific part of the population, and they're already prone to have positive ideas about microdosing because they're the people who contacted the microdosing researchers. So contextualizing that and not just throwing out that evidence, but understanding what it can be used for and how that can inform clinical studies, I think is really important.
Yeah, no, I agree. No, that's a great point. I appreciate you making that. So yeah, what I wanted to ask next is I want to ask each of you, like, what is a microdosing clinical study that you would like to see in the near future? We could start with you, Sophia, if you'd like to chime in.
So I don't do clinical research, I do preclinical research. So I collect all these anecdotes and then I talk to clinical researchers and we look at the evidence base. So we have a bunch of things that clinical researchers have indicated they want to follow up on. So we have like 6 stories of people who have had paralysis in some way, who have had, when they were microdosing, started having movement in those paralyzed parts of their bodies. So that's very interesting, but it's not something that I do research on. That's something I sort of hand over to the clinical researchers. We have not done any research on people with autism spectrum disorders, because we were advised that parents with children with autism spectrum disorders are so desperate that if there was any evidence that there could be help, that they would give their kids psychedelics. So we were concerned about the risk of harm there. But some adults have written to us and said that LSD has been very helpful for them, but we'd have to do that in a very safe way. There's a number of women who have menstrual disorders of sort of different kinds that have said that microdosing has been very helpful for them. Like one person I know who had to go to the hospital every month to have blood transfusions. She was losing so much blood during her menses, and she's microdosing a very small amount, say 2 micrograms a month, and is not having that problem that she needs to go to the hospital anymore. So those are like, there's many different sort of medical groups that we'd be interested to see follow-ups on.
Yeah, no, that's all fascinating. I would love to see follow-ups on all of that as well. David, Luke, is there any study that you'd like to see? Not necessarily that you'd like to conduct, but just like to see. I would love to hear.
Yeah, well, I have to say I'm slightly a fraud here. I've been involved in microdosing research, but I'm more of a macrodose researcher, really. But it doesn't mean that the microdosing doesn't have any interest. And I kind of really salute Sophie there in working from the bottom up. So what kind of things do people report that have benefits? And all the classic things, creativity, enhanced focus, all the rest of it, and also people report reductions in depression and anxiety as well. So all of those things really need kind of thoroughly investigated, and all the other interesting stuff that Sophie pointed out. For me personally, because I have a rather kind of quirky interest in this area in psychology, I think it'd be interesting to see if and when these studies come through with a well-controlled, RCTs, and we're finding some effects, but maybe not as impressive as people self-reports, then I think it's worthwhile investigating perhaps the power of that it has on accelerating the placebo in some way, if that is genuine. I.e., we know from LSD increases suggestibility. Is that even possible as well at microdose too? So that'd be what I would look at.
Super interesting. Yeah, and David Aritza, would you like to comment?
Yeah, I want to. So at Luke's wonderful conference in London, Breaking Convention, I actually did my first microdosing talk where I promoted that we soon would come with our results from a randomized, blinded, placebo-controlled trial. So we have the data, and it's under review, so it has been submitted for publication. So I sit here with a lot of results in my head that I could share. So of course, basically, it's the biggest study in modern era of any psychedelic in a randomized placebo-controlled setting. But it's a very strange design developed together with a wonderful colleague called Bala Shigeti, who came up with an idea that we could basically sort of exploit that this is a phenomenon going on. People are microdosing on their own initiative, using their own drugs for a lot of different purposes. And what we then offered was a manual that was also made into a YouTube video that people signed up, consented before they did the microdosing regime, and then basically followed the manual and thereby blinded themselves, following a quite complex manual where we basically made it possible for people created a 4-week regime with a planned microdoses at a couple of times, 2-3 times a week, as they were planning to do anyway. But if they followed the manual, then they would make a mirrored version of the 4 weeks with a placebo version of it. And then the envelopes, each envelope representing 1 week, was then mixed up in a certain way. And in each envelope, there were QR codes. And then on an app on their phone, they could scan in what was in the envelope. So we ended up with, we knew that from the beginning because we had piloted it with 3 groups, one that were microdosing properly for 4 weeks, and 1 group that would take placebo for the entire period, and then 1 group that microdosed 1 week placebo, 1 week microdose, 1 week placebo. And then we had before, so at baseline, before they started, we had a lot of measures, who they were, why did they do it, what were their expectations, mental health, physical health history, what drug were they using, what dose, and then we, during the 4 weeks and follow up in the end, and 4 weeks later, so a month after they stopped, we did a lot of assessments online and cognitive testing and a lot of things. So I'm not saying that is the study that I would want to do, because we have already done it. So we would like to we would like to basically obviously do the more expensive and complicated thing, which would be a proper trial where we have full control of the dose, all these things that you can attack in terms of science on this kind of trial, that we would close all these gaps. But that's very, very expensive and very difficult to do a microdosing trial. One of the reasons is that one thing is giving people a full dose psychedelics. We do that in a number of lab-based trials, but that's one-off or two doses. If you want to do it in a microdose many, many times, the only feasible thing would be to give people the dose to take home. And they recently got acceptance for doing that in New Zealand. But that is tricky to get approvals for. And otherwise, if you have people to come into a lab to take a microdose and sit there instead of going to work in a boring lab 3 times a week for 4-6 weeks, that's a lot of waste of time and resources, and you need a lot of staff. It's very invasive for the participants, and you're actually also pulling them out of the naturalistic setting. So it's tricky. So that's why we came up with this sort of in the middle kind of homemade novel methodology where people basically could blind themselves.
That's so fascinating. So excited to read that when it comes out, and so interesting. That was going to be my question. Like, would people take it home? Would they take it in the lab? Oh, can't wait to see where this is going. Really appreciate that.
Yeah, I know the University of Toronto is doing a lab-based one right now. And it is like an artificial environment. Yeah. Like
interesting.
Yeah, but that's deeply interesting what these trials will show. Yeah. And also, I would say one thing I think maybe for the people looking at this panel discussion, I think it's important to think about the different levels of evidence, because one thing, you have an anecdote, right? That's pretty low evidence, because what is that? If you do it retrospectively, that's that's even lower. If you ask, how was it to microdose? What did you get out of it? That's biased how you look at it backwards and so on. So it's a bit stronger to do a prospective thing where you actually assess stuff before people start doing it. The problem with that is that it still could all be one big placebo. I mean, it really could. If people are expecting this to work, even if you follow them from before to after, it could show great evidence. And a lot of the studies so far, they show that evidence, but it's weak evidence. It shows that it improves all these things that several of you already talked about. Whether it does that beyond placebo, we know from our trial, in this trial at least, that I don't know, should I reveal it? I mean, I don't know if it's then I'll be blah-blahing, or we can also hear what other people have to say.
Well, if you want to reveal it, I'm very curious.
Yeah, I think one thing to note is that there's when we talk about the placebo effect, there's multiple different placebo effects that get sort of added together. So one thing I like about the design with the envelopes is that it reduces the part of the placebo effect that is the relationship of the investigator and the participant. So where they feel cared for. So many trials have that as a component where someone's giving them the substance. So the feelings of professionalism and being cared for by the researchers creates more of an additional part of the placebo effect.
Because they want to please the person that's giving them the medicine. Is that correct?
No, because they feel cared for. So that in itself is helpful to people. So the placebo effect is like all the things that make someone feel better, right? So feeling cared for is part of that.
Oh, that's so interesting.
Yeah. And feeling like you're talking to an expert is part of that.
But I mean, I think the whole idea with an RCT, so a randomized double-blind placebo-controlled trial, is to kind of get rid of that, because you try then to have people getting exactly the same package, getting the same sort of placebo tablet under the same conditions, so you try to sort of control for that by that design. But you're right, in this study, there wasn't much at all involvement. We never met physically the participants. We only had email linked to them. And then it was all done remotely. People could participate from Buenos Aires, wherever they were. And for whatever reason, we just collected tons of online knowledge about them.
That's brilliant, David. I think
it's really brilliant. Yeah.
It's amazing. I mean, I'd like to echo what you were saying there as well. And certainly in the RCT I was involved in, we had people in for like 4-day periods. It's very difficult to staff these studies. Obviously, it's very expensive and labor intensive. But we did it in a clinical trials center in a hospital, and we didn't get very good results. I mean, in terms of changes to cognitive function, there was no significant effects at all. I'm thinking now, in relation to what you've been saying, it could well be that because it didn't have this kind of prolonged period of time, it was only for a few days at a time, and then there's washout periods as they moved around the different groups and tried different doses. So, and the other factor is that there were over 55s, but on the limited cognitive battery we gave, there were no improvements or no.
So I gave a cognitive battery to some volunteers who were microdosing who reported that they were feeling smarter and getting more work done, and I did not see any cognitive change. So the instruments that I was using. What's that?
No, you just had a bit of a lag. Sorry. Could you finish what you were saying?
Sorry. So I did. Yes. Sorry. I gave cognitive tests to volunteers who were microdosing, and I did not see any cognitive change. Even though they were reporting they were doing better at work. So it's possible that the instruments that I was using didn't capture what was happening, because people are saying they're not procrastinating, which is sort of this either high level or low level task. But yeah, there's no change in digit span. There's no change in a bunch of cognitive assessments.
Really interesting. I'd like to go into that a little bit. The idea that microdosing helps people be more productive and focused and get more work done. I guess I wanted to ask you all, are there any theories of how this is working, how it's increasing concentration and focus? And you hear the word flow and flow state tossed out a lot when people are talking about this. But could one of you or all of you explain what you think is really happening? How is this working?
I mean, again, sorry, before any of us try that, I would say, does it?
Yeah. Okay.
Does it? So it's interesting to think about how theoretically it would work. But before we even start thinking about that, it would be nice to see whether it does work beyond placebo, because otherwise we might as well talk about how does placebo make you concentrate better.
Yes.
You know.
I'll take anything. No.
Yeah, and is it Gasser in Switzerland, who did the 2017 study on LSD and people's anxiety around death. So he pointed to 3 cognitive changes that were changing people's anxiety. And we see similar things with microdosing, but that could be, so it's looking at hierarchies differently, taking a step back, looking at relationships differently, flow states. So it's possible that those are always the things that people point to if there's been a change, whether or not they take drugs. So it's possible that if there's a big change in how you see things, it's always because you took a step back from looking at the hierarchy in the same way, or revealing something about the relationships with yourself and other team members or something. So if we don't know if it works, but however it works, it might be the same cognitive processes in humans that allow us to solve problems better.
Interesting. Very cool. Yeah, I look forward to more research on it for sure. And then, so the other big group that, folks talk about receiving benefit from microdosing is those with depression. And I feel like I read in some of your and James Fadiman's work, Sophia, that's the group that you receive the most self-reports from, folks with depression. Is that still true?
So it's a little complicated. So we ask people what their expectations are before they microdose. And we give them also we're giving them an inventory of an emotional assessment. So some people said that they were depressed and they wanted to microdose to relieve that. And some people who said they wanted to microdose because they wanted to be better at work also tested like they had depression.
Interesting.
Yeah, around the same number of people who said they were having a problem with their mood, and people who didn't say they were having a problem with their mood tested like they had depression. So that becomes a very large group.
Yeah. And I guess I wanted to ask, and I guess there might not be an answer for this yet, but any ideas on why this group receives so much benefit from microdosing?
So all the things we were talking about before, these are a self-selecting population of people who have usually had a positive experience with psychedelics in the past. So those are lots of and they're communicating with James Fadiman, who's an expert in the field for 40 years. So those are all things that will increase the placebo effect and have to do with self-selection of the group. And it's possible that there's an improvement of mood of people who have microdosing.
Yeah. David, Luke, did you want to add to that? I thought I saw you perk up.
Yeah, sorry, no. Well, I wasn't involved in that study. I mean, again, as David says, you know, we can't be certain it's not placebo until we have better RCTs, and the little we have done has not really, and very little. I mean, it's been like 2 or 3 RCTs. It hasn't really produced very much, as one came out last month. But you know, that what we do know is that that microdosing enhances supposedly neurogenesis, right? So there is for sure some physiological effects going on, right? There's going to be some activity, right, even at those low doses, even if it's subperceptual, and so that should have some effect. And we found dilation in time perception, even in the absence of any kind of subjective experience, right? So that it's having some cognitive effects. So you know, people are going to feel more spacious and things like that, perhaps, but not enough that they can perceive it necessarily on a kind of a threshold.
Yeah, no, really interesting. I was rereading that study recently on the LSD for time perception, and it kind of reminded me of the productivity and the flow state thing as well. Maybe things just feel a little bit more slowed down. People are just able to focus a little better. But I also want to ask, I mean, so I get a lot of emails about this personally, about folks who want to know if it's safe to microdose while they're still on some kind of antidepressant, like an SSRI or an SNRI antidepressant medication. Is it safe to be mixing a microdose of psilocybin or LSD with these medications?
So on our website, we have a list of all of the medications that people have microdosed with and have not had a adverse effect, and the medications that people have microdosed with and had an adverse effect. I think that that's the biggest data that we've got right now, the randomized controlled trials are people, I think, who are on other medications. So it seems like on most of the, I'm sorry.
You just lagged a little. Just continue. We just couldn't hear you for just one
sorry.
second.
Yeah. So we have a list of people who, what medications people have used successfully with microdosing, and ones that people have had adverse effects, like lithium. And so that's like one source of data. It's not a huge amount. We do know that SSRIs affect macrodosing, reduce the effect of LSD. And I do think that you guys could, the Davids can correct me if I'm wrong, but I think the randomized controlled trials are excluding people who are on other medications.
So in some studies, we do wean people off SSRIs. In other studies, we don't. We are going to soon do a study in OCD patients where we probably won't, because we don't have any proper evidence that it's dangerous to be on for instance, with psilocybin, to be on an SSRI. There's some, I mean, and SSRIs, it's quite a lot of different drugs. We also have other kinds of antidepressants. So it depends a bit on exactly what we're talking about, and we don't know enough yet. But it's not that we have any strong suspicion that it's massively dangerous to be on an SSRI and take a psychedelic, a classic psychedelic. However, if you start taking ayahuasca, it has MAO inhibitors, the harmalins in it. That could potentially be quite tricky because you could get serotonin syndromes, at least theoretically. That is very tricky. But a more pure compound like psilocybin or LSD, probably less problematic. But then there are other antidepressants who might be more tricky to mix in, like mirtazapine, which has serotonin 2A blocking effects. Then you'll definitely block a lot of the effects. So it depends a bit what we're speaking about. And I think we'll find out more when proper studies are being done, where you test plasma levels and all side effects much more carefully in a very controlled manner. We'll know more. And I think the big pharma companies who are developing these, they will have the interest in figure that out. I'm sure that will make total sense to investigate some of that along the way over the next few years. I'm sure they will do that. It will be interesting. When it comes to the potential antidepressant effects, I think it's important to stick with what David Lucas said, that the clinical trials so far where there had been a placebo condition, they don't show much. They really don't. And I think it's about also paying attention to what they don't show effects of on, and also be aware that they are most often very, very few doses because of the complexity and the costs related to conducting a long-term trial. So in a way, it's a snapshot of microdosing. It's not the real microdosing where people are doing it for a sustained period of time. Those studies, as we already talked about, are complicated to conduct. in terms of whether it could have antidepressant effect, for instance, I think it's important to mention that the doses that people are microdosing in, we know now from PET studies in Copenhagen that those doses, they actually are still to a level where they will have a significant impact on the serotonin to the psychedelic receptor where the full doses work through. So it's not that they're only touching a couple of percent of receptors, they're actually up in 30-40% of receptor stimulation, which could theoretically be pharmacologically significant, and therefore there is theoretical the opportunity, the possibility that they could have proper pharmacological effect in the microdosing range, because psychedelic microdosing range is not pharmacological microdosing range. That would be much lower. Then we are down in much lower doses. Then we typically only want to affect at 1% of receptors in order to speak about pharmacological microdosing. So psychedelic microdoses are more in the range of what you could maybe call mini dosing if you speak about pharmacology. But whether it works or not, I'll say that our study it doesn't look like it have any effects beyond placebo. Really, it's very driven by expectation. No matter what we look at, whether we look at acute effects, accumulated effects, whether we look in a subpopulation of people who at baseline have some depressive and anxiety symptoms, if we look at them, it's the same thing all over. That the predictive value of what people think they're taking is 10 times higher than what they actually take in the study. So if you maintain a proper blinding, so people really don't know what they're doing, doesn't seem to do much. But if you look at the microdosing group alone in our trials, it totally confirms all these very positive and exciting and promising trials where you have looked at surveys. So if you look at the microdosing group alone, everything becomes better. I mean, well-being, everything. I mean, anxiety and depressive symptoms.
Wait, I want to check about anxiety. Yeah, so you showed a benefit for anxiety, because we were showing a negative, that people who were microdosing were reporting that they were more anxious.
Yeah, and you're right. It's also about putting emphasis to the negative findings in studies, or maybe unpleasant effects. And some of the trials, they report 20% of the participants, even in those trials where you might have a selective bias of getting people who are quite pro microdosing into the studies, they still see 20% reporting quite negative stuff. There's also one study, prospective, showing increased in neuroticism, which is not a brilliant thing to have an increase in. And we didn't see many negative things in our trial, to be honest. We saw a lot of amazingly positive things, completely in agreement with the nicest results from other prospective trials. But when we look at the placebo group, it shows the same. And
that's
then when we
Thank you.
And when we go into looking at their ability to break blind and asking them, what did you think you had today? And we can see when they guess incorrectly, when they thought they had a microdose, but they had placebo, they performed well on all measures and scales. If they thought they had microdose, the other way around, if they thought they had a microdose, but they actually had placebo, no, if they actually had microdose, but they thought they had placebo, they don't do well. So the what they think they get is 10 times more predictive of the outcomes than what they actually took, which is kind of not extremely promising for the potential of microdosing. Without saying that it doesn't work at all, I won't say that. But I'm saying it doesn't look super promising from this study.
So interesting, fascinating. I do want to go into a little bit about the potential risks, especially of like a chronic microdosing, taking this every day or every third day. There is a lot of anecdotal reports on the positive stuff, but do you think future research should also focus on some potential risks in low doses? And, is it really safe to be using a psychedelic even at this dose for extended periods of time? David?
I'm going to defer that to David because he's a psychiatrist. He's better medically trained than I am. But
exactly.
and there are some concerns about, cardiac issues, perhaps.
Yeah, that's kind of what I'm getting at. I've also heard of that from some researchers at Johns Hopkins, but I'd love to hear what you have to say, David.
Oh, me? Well, only that.
Or I meant other Davids.
Yeah, good, yeah.
But So obviously in this trial that we have just conducted, we really is absolutely impossible to assess. It's a big global study. We don't know, but there are previous medications that have been on the market that stimulate the 2B receptor, which is another serotonin receptor. So that's not where the key action of psychedelics are through, but it's another serotonin receptor that sits a lot in the periphery, so out in the body, including in the heart valves. And studies that stimulate that receptor, some of those have been pulled back from the market because they cause fibrosis on these heart valves. So they cause significant problems to the heart. And the psychedelics, a lot of them, they do have that same ability to stimulate that receptor. And when it comes to very few doses, even large doses, full psychedelic doses, we don't have any, I mean, it has been used, as you know, for hundreds, if not thousands of years, a lot of cultures. We don't have any, nasty cardiac thing coming from psychedelic communities. But the microdosing is different because of the very repeated over much longer periods. So it's much more doses, much more frequent. Is that a problem? I think the short answer is we don't know, but that is something that should be possible in animal studies to really look into. And I'm sure somebody's doing it as we speak, I hope, because it makes sense to be on the safe side and check that. It's not that we say that is extremely likely that it will cause fibrosis, but it should be ruled out.
Yeah.
I think that Dave Nichols has created a psilocybin variant that doesn't affect 2B, but I'm not sure.
There are some new selective psychedelics, like also the N-bums. Some of them are extremely selective for the serotonin 2A receptor, but they are actually very, very dangerous. So people have died from those. And so it's a bit tricky, to be honest. Sorry?
Nature usually knows best.
Exactly. Yeah, it's a good point. And also, even though if you have a sort of main compound, which is the main drug, that is very selective for the right receptor, for the 2A receptor, it could be that it metabolizes in the body, and then you have a metabolite that then stimulates one of the baddies, and then you might have the problem. So it's not very simple. It's not just looking at the main mother compound and see whether that looks good in its profile. You also need to look at all the metabolites. So therefore, we know that the classic psychedelics are very physiologically very safe, but whether they are safe when you very frequently take them, that's another story, because that's not what we're used to. That's not what humans have done much. So we don't know.
Yeah, no, very interesting. It's something I've been hearing from other researchers as well. So something to keep an eye on for sure. I know we only have like less than 10 minutes, but one question I've been meaning to ask researchers is, LSD and psilocybin seem to be the two most popular substances to microdose. I was wondering if anyone could speak to what the difference between microdosing these two substances might be for an individual.
We don't see any difference in our sample between people who microdose psilocybin and people who microdose LSD.
Exactly the same from our trial. We didn't see any difference in any results for the two.
Interesting.
You get a shorter acting placebo with psilocybin microdosing.
The what, sir?
Shorter acting placebo with microdosing psilocybin.
Right. Well, that's what I was thinking. Maybe at least it was just the length it lasted, but you've answered that. Thank you. I appreciate that. Yeah. What else do I want to ask you guys? So, I mean, we've talked a little bit about obstacles to research, mostly money, because it is very expensive to have, all the people involved, all the care, the trip sitters and stuff involved in psychedelic trials. I was wondering, what are some other obstacles specifically to microdosing research that you guys are up against, or, that exist in the science community?
Yeah, one problem has been as pharma companies and capitalism enter the psychedelic space, there's been anti-competitive action by some of those companies. So one company in particular has paid off pharmaceutical factories to not make GMP, which is the type of LSD that you can do research on humans with. They paid off all the other factories to not create any for other researchers, so that only this one company would be able to produce psychedelic research. So I spent a number of months talking to different pharma companies in order to create another source of GMP, but that was a huge obstacle for a while.
Interesting. I haven't heard of that. Wow.
Mhm.
Any other
No,
obstacles?
I think that other companies, other people, other companies and academics are producing also psilocybin that is to the same standard. So I
Yes,
think,
yeah.
I don't think that's a big issue. Of course, nobody wants anybody to have, you know, monopole on anything. I don't think any companies really want it either, because anyway. So I hope that's not a big issue. I think one thing, I mean, and this is not to be so totally self-centered about our trial, but obviously it's not going to help much if for raising funds in the future, probably, and investors, if we come out with the biggest, you know, placebo-controlled trial in psychedelics in modern era now with microdosing, showing that it does not really do much beyond placebo. And also we can see that the effect sizes, if we were to want to see, like, if we were to have a significant separation between microdosing and placebo based on our results, you would need to have 1,500 people in each group or something like that. So it's yeah, which is not very, you know, promising for raising funds to do trials, because you would need massive trials to show anything, and I don't think investors would be that interested. However, investors are very interested in microdosing so far, and hopefully, I wouldn't say hopefully we are wrong. I think there's not much wrong with our trial, but you know, it could be that another trial come out and show that it's much more positive. However, then I would start arguing, questioning, have they taken into account the ability to break the blind? Because I think that would be very key, not just for actually psychedelic, but also to look more into, also when you look at normal pharma trials with SSRI and so on, are people able to break blind or not? Because sometimes that's ignored a little bit. We took that into account here and basically see, because we took it into account, that it really looks like it's very much driven by expectation. So now I would brought it back to our own trial, but you know, I think it will be possible to raise funds to do microdosing trials. I think there are more and more investors that are very eager to step into this market, because it's potentially a massive market. It's one of the biggest conditions on the planet. Just depression alone, mental health in general, is massive. So could it work? It would be amazing. It would help a lot of people. 30-40% don't really respond to normal antidepressants. It would be incredible if it really had effect. It just doesn't look very promising.
So David Arizzo's excellent research is an obstacle to microdosing research.
I know. So we did the study. We did the study in order to produce some early evidence to then raise funding to do proper research. And now we have done the study and we have basically shot a massive hole in our own foot. But it's science. It's interesting. It's fascinating when you get a bit surprised sometimes. And
it's a good thing. Like, if it's not helping people, then maybe we shouldn't get funding. Yeah.
Yeah, exactly.
Or not funding for depression, right? Depression for these medical conditions that we weren't expecting to see a benefit from. Yeah.
I mean, people think it's helping them, that is kind of valuable in itself. I mean, right? But is it worth the kind of potential risk of, you know, cardiac problems? I mean, that's for, you know, to establish. But the effects are so small. I mean, it's kind of parallel to perhaps the effects of aspirin on cardiovascular disease. You know, very, very small effect size. It has effects, but only when you have enormous groups. That probably isn't good enough, really, for the kind of use.
And also, coming from a commercial question about how do we get the money, investors, you know, funding bodies that are from governmental money, in order for it to make sense to really step into it and promote it and drive it towards a license and so on, there need to be some people who believe in that the effects are significant and big enough for it to make sense to develop. And this could be that there is there are some people in companies in America trying to develop, I think, a LSD microdosing for ADHD. If that worked, it would be great. If it shows it in a double-blind controlled trial, then go for it, and then take that towards licensing. That would be great. So hopefully there will be somewhere where it worked, because it would be great if it worked for something. You know, every new treatments are valuable, an extra tool in the toolbox in mental health.
Mm-hmm.
Agreed. Yeah, we're coming up to the end of our panel here, but this has been so interesting. I really appreciate all of your time. Does anyone have any last words before we finish this up? Any last things you want to say about microdosing?
I've only got to say that, just in case, I've noticed there's been a lot of time lags going on in this. I don't know if it's just mine or if everyone's microdosing or something, perhaps.
Are you microdosing today, David?
No, just my Wi-Fi.
The time perception.
Your Wi-Fi is microdosing.
It's your time perception.
Yeah.